Thank you. So we're now gonna listen to Alex Wyatt's presentation.
Good afternoon, everybody. I'm really sorry I can't be there in person. My flights were unfortunately cancelled and I couldn't make it in time. But I'm very grateful for the opportunity to present virtually at least and participate in the upcoming discussion as well. Here are my disclosures. So I'm going to be talking today about ctDNA as a response biomarker. So I'll start with what exactly is plasma cell-free DNA. And I think many are aware this is apoptosing cells that shed their DNA into the blood. And most cell-free DNA in blood plasma comes from your dying white blood cell populations. And the average person has 5 to 10 nanograms of DNA in 1 ml of plasma. That's cell-free DNA. So that's about 1,500 cells worth of DNA per ml of blood plasma. It's quite fragmented DNA. It's the median fragment length is 167 base pairs, which is the unit of the nucleosome because the apoptotic machinery cuts either side of each nucleosome. And in a person with cancer, a fraction of your total cell-free DNA is tumor-derived, and we call this the ctDNA fraction, the circulating tumor DNA fraction. It's slightly smaller ctDNA than cell-free DNA, but the distributions very closely overlap. So we can't use size alone to detect ctDNA, so what we do instead is we look for mutations or rearrangements or methylation marks that shouldn't be there in the patient's germline or normal cell-free DNA. And one of the most important concepts for today's conversation is that ctDNA fraction is closely related to how much active and proliferative cancer you have in your body. So prostate cancer happens to be a high shedding disease, as in it's associated with reasonably high ctDNA at times of clinical progression. The same is true of bladder cancer, but it is not true of, say, kidney cancer or testis cancer. So in prostate cancer, if you have metastatic clinically progressing disease, you can expect your cohorts to have a median of 5 to 25% ctDNA in their blood. It's somewhat clinical state dependent. So if you take a really heavily pretreated cohort, late stage, you're going to see higher ctDNA fractions on average than an earlier stage cohort. And as you might expect, anything that indicates that you have higher tumor burden is going to associate with ctDNA fraction. So, for example, in a recent unpublished study, we've seen that if you have high ctDNA, you're more likely to have high FDG metabolic tumor volume, which makes sense, the concept of proliferative active tumor and high ctDNA. And conversely, the low ctDNA is associated with higher PSMA SUV mean. So because of this relationship between ctDNA and other metrics of clinical tumor burden, we see very strong relationships between ctDNA fraction and disease prognosis. So if you have high baseline ctDNA, you tend to have poor PFS and OS across treatment contexts and lines of therapy. And whereas patients with low levels of ctDNA seem to do the best with most of the treatments that we have available at the moment. Once you start treatment, we see very quick declines in the first days and weeks of treatment in ctDNA fraction. So on the right and the middle here is castrate-sensitive disease initiating ADT. Within that first week of treatment, big declines in ctDNA. On the right-hand side in the CRPC setting, once you start ARPI in the first-line setting in this context, but after one cycle, we see much depressed ctDNA fraction compared to either baseline or progression. And you can see this here in a cohort. This is one of Greta Tard's cohorts. This is in the context of chemotherapy, the same thing. After one cycle of treatment, you see that CT fraction is much lower than at baseline or progression. And this molecular response converts to clinical responses as well. So patients that clear ctDNA, i.e. you can't detect ctDNA after one cycle of treatment, they have much better progression-free survival and overall survival than patients that have persistent ctDNA. And all the indications seem to be that this outperforms our other metrics of early response, including, for example, PSA. And what's really exciting is this is not just something that's specific to one line of treatment or one type of therapy. There's consistent evidence across classes of treatment and across lines of therapy. So in the context of androgen receptor pathway inhibitors, lutetium PSMA, taxane chemotherapy, PARP inhibitors, we see that early changes in ctDNA associate with outcomes, particularly progression-free survival, but also overall survival and even PSA response rates. But critically, the information that we're getting from that ctDNA kinetics seems to outperform at least PSA in the early setting as well. So this is not something that's just being observed in the context of prostate cancer. Across solid tumors, we're seeing that there's associations between ctDNA kinetics on treatment and patient outcomes. And so there are several international efforts trying to develop ctDNA fraction as a response biomarker. And I'll highlight one in the US, which is Friends of Cancer Research have been working particularly in the context of lung cancer and immunotherapy to try to develop early ctDNA measurements as an intermediate endpoint. I've been working with one of the academic groups, the RESIST working group, to evaluate the added value of ctDNA kinetics at imaging-based assessments. And you can imagine this is particularly relevant for prostate cancer, where most patients are not actually RESIST evaluable. We put out a white paper late last year. This is not guidelines at all. It's more sort of what evidence do we need before we can move towards guidelines, really highlighting the promise, but also what we need to do to better understand the path forward. And I'll just highlight some of those so that everybody is aware of them. So I think at the moment, we don't have a full understanding of cell-free DNA basic biology, like what contributes to increased or decreased shedding, do comorbidities or treatments interact there? We don't, partly related to this, have really established thresholds for what constitutes a clinically meaningful change in ctDNA. We're quite comfortable with saying total clearance, but to some extent that's subjective based on the assay that you use. And we don't know, well, does a 50% decline matter? Does a 1% increase matter? We don't really understand that yet. Linked, of course, is that we have large variation in the assays that we're using across studies, and each with different limits of detection. And we also don't know when is the best timing for blood collection. Typically, we look when it's convenient, right? End of a cycle, start of another cycle, but it could be days after treatment initiation. And you may need a confirmatory blood sample to be sure of a change. I think particularly relevant for European audiences and Canadian audiences is what is the actual feasibility of implementing ctDNA testing? How much would it cost for hospital labs to operate such tests? And lastly, probably one of the biggest elephants in the room is that not all patients are actually ctDNA evaluable. Some patients have very low ctDNA. Perhaps this will be solved with improved assays over the years, but it's the reality right now that most approaches we use don't find ctDNA in everybody we test prior to treatment. I'll just highlight that the FDA recently released draft guidelines on the use of ctDNA as a biomarker for response in clinical trials. They highlight a lot of the promise, but also some of these issues that I'm highlighting on this slide. So how do we go forward in prostate cancer? Well, I think we should pick specific clinical scenarios and treatment classes to go after. And certainly we need more large correlative data sets and meta cohorts. And I think this is we're at a real opportunity right now to embed more blood collections in the protocols of our academic trials, and encourage our industry partners to do the same. I think we need to really get a better handle on those potential biological confounders of CT fraction change, things like, well, testing blood in the morning or the evening, or understanding whether an adverse event increases more cell-free DNA shedding. I think last point on this slide is to highlight something that I feel quite passionately about as an opportunity for the future, which is designing randomized trials that intervene on the basis of either ctDNA clearance or non-clearance, so ctDNA persistence. And so examples would be that if you have complete clearance of ctDNA, perhaps we can reduce dose of some of our more toxic compounds. Whereas patients that don't clear ctDNA, perhaps that's an opportunity to test whether treatment switch or intensification is impactful to patients in that context. These will require randomized trials, but I think we're at the point where we could design these now. So what's my conclusions? Hopefully, it's clear that plasma ctDNA is quite high on average in prostate cancer with metastatic disease. But that once you initiate effective treatment, you get rapid and deep declines in ctDNA. And these declines associate very strongly, actually, with radiographic PFS and overall survival, and seem to provide more prognostic information than our current blood-based biomarker in PSA. So therefore, these ctDNA kinetics that changes over time, I think offer promise both as routine response biomarker, but also an early endpoint in clinical trials and even an opportunity for intervention. But what's clear is for us to move forward as a field, we absolutely need more correlative data from all of our ongoing trials to better define how to assess a clinically meaningful change in ctDNA fraction. But I'm really optimistic about this as a biomarker, and I see great potential going forward. Thank you very much for listening, and I look forward to the question session.